Hi, everyone. My name is Stephanie Send. I am a nutrition support dietitian in Chicago, Illinois. And today we're going to be talking about short bowel syndrome. So, what is SBS? Short bowel syndrome is a chronic condition in which extensive small bowel resection or disease process leads to the loss of intestinal function and absorption capacity. So what's important to know is the severity of SBS depends not only on the length of the small bowel that's resected and removed or affected, but the segment of the small bowel as well. So are we talking the ileum, the jejunum, and that is really important to note. So classification of SBS. So who is defined as having short bowel syndrome? So we need to look at the length of the normal small bowel when we're talking about this. So in an adult patient, the normal length of small bowel is anywhere from 400 to 800 centimeters, which is equivalent to 13 to 26 feet. Most adults, their small bowel length averages around 20 feet. So when we're talking about someone with SBS, this is someone that has had at least 75% of their small bowel resected, removed, or diseased. So those with SBS range from having acute intestinal insufficiency to chronic intestinal failure. So common causes, thinking in the pediatric population, what might cause SBS, that might be a congenital malformation or infection in the pediatric patient. So thinking of your NICU patients that might have necrotizing enterocolitis, gastroschisis, or intussusception are common causes of SBS. So looking at the adult population, generally we see SBS in patients that have undergone a massive surgical resection. For example, a patient with Crohn's disease, someone that has mesenteric ischemia or vascular complications that leads to bowel resection, a malignancy or radiation enteritis that damages the small bowel, trauma cases, also surgical complications such as fistulas, infections, and adhesions, which might lead to more surgery. So what are the symptoms and complications of SBS? So looking kind of short-term or things we might see right away in an SBS patient, this could be chronic diarrhea. So with that chronic diarrhea comes many complications such as dehydration or electrolyte derangements, which we'll talk a little bit more about. Also with that is steatorrhea, which can cause macronutrient and micronutrient deficiencies, can lead to weight loss, and with that lead to malnutrition. So another complication is food intolerances or aversions, which is more common in the pediatric population just from being advised by healthcare providers to avoid certain foods or having negative reactions to certain foods. Looking at more chronic complications of SBS, one of these is metabolic bone disease. So this can be caused by a variety of factors such as inadequate mineral intake, calcium and vitamin D malabsorption, and chronic steroid use, especially in our IBD population that might be on long-term steroids. Nephrolithiasis or kidney stones. So this can be caused by both dehydration as well as fat malabsorption that can lead to oxalate accumulation, which results in kidney stones. Another complication is hepatobiliary issues. This could be PNALD or parenteral nutrition associated liver disease, which can be caused by exposure to phytosterols, specifically coming from soybean oil-based lipid emulsions. Micronutrient toxicities can also cause hepatobiliary complications, and then reduced enteric stimulation. So thinking about those patients that are strict NPO or have chronic poor oral intake. So nutrition recommendations. So it's important to note that these recommendations depend on if a patient has a colon in continuity or not. So does that patient have intact bowel, or do they have an angiogenostomy? So for both types of patients, calorie needs can be anywhere between 35 to 45 kcals per day. Again, this is patient dependent. You need to consider other disease states that the patient might have, their BMI or recent weight loss. Also important to note, calories coming from not only oral diet or enteral and or parenteral nutrition. For the patients that have a colon in continuity, carbohydrates should make up a majority of those calories. So thinking 50 to 60% of energy intake coming from carbohydrates. This is because these calories coming from carbohydrates are more easily absorbed for a patient with a colon in continuity. Protein needs are generally on the higher end, so 1.5 to 2 grams per kilo per day for protein, and that's across the board between these two different subsets of patients with SBS. So for patients with a colon in continuity, fats should make up about 20 to 30% of total energy intake. And in addition to that, fiber is recommended 10 to 15 grams per day, dependent on tolerance for patients with a colon in continuity. Looking at the differences with those with an angiogenostomy, most important to note is the carbohydrates and the fats. So those with an angiogenostomy should have a lower intake of their carbohydrates, so making up 20 to 40% of total calories, and fat should be a higher percentage, so 40 to 60% of energy should come from fats. And that is because these patients, the higher intake they have of fats, the more potential for absorption of some of those fats. So for oral diet recommendations, I would recommend small frequent meals. So this is extremely important. We want to minimize the volume going in at one time in hopes for better absorption. It's also important to separate liquids from solids, so avoiding large volumes of fluid intake when a patient is having a meal, again, just to minimize the volume going in at one time. Fluids should be isotonic or hypotonic fluids only, which we'll discuss a little bit more. And fluid should be sipped throughout the day. So we don't want patients, again, to have large glasses of water or glasses of fluids, at one time. We want to kind of spread this out throughout the day. Simple sugars should be limited. So examples of this would be juice, soda, candy. So these foods have a very high osmotic load, which can lead to dumping and loss of fluid and nutrients that way. And we should be encouraging complex carbohydrates. So thinking foods like pasta, breads, rice, mashed potatoes, because these have a higher chance of absorption when compared to the simple sugars. High protein sources should be encouraged. As we discussed on the last slide, protein needs are higher in the patient with SBS. And for those with a colon, again, encouraging the soluble fiber, and also encouraging lower oxalate foods for those with a colon in continuity, just to reduce the risk of kidney stones. And liberalizing the use of salt. So patients with SBS have really high sodium losses, especially in those with angiogenostomies or ileostomies. So encouraging your patients to use additional salt with their intake and not be restricting this. So fluid choices are extremely important when you're looking at your SBS patient. So recommending oral rehydration solutions, or ORS. These can be both homemade or commercial. There's a lot of different products on the market for this. Other examples of fluids that are acceptable are milk, diluted juice, so thinking half water, half juice mixture. Sports drinks are not good options for patients with SBS due to the high sugar content, because that creates a high osmotic load. And again, sugar-free beverages are also not a good option due to the sugar substitutes or sugar alcohols that are used in these products, because these can be poorly tolerated in those with SBS and lead to higher fluid losses from stool output. Plain water might be okay for those with a colon in continuity, but plain water does not contain that optimal ratio of glucose and sodium that's needed to facilitate fluid absorption, such as the oral rehydrations do. So it is advised to have more of the oral rehydration solutions and less focus on just plain water. So when we're looking at the components of an oral rehydration solution, we want to look at the sodium content as well as the glucose content. So the optimal sodium content is 90 to 120 milliequivalents of sodium per liter of fluid. This is, like I said, the optimal or the ideal ratio. However, this amount might need to be decreased just due to overall tolerance. We'd rather our patients drink more of these oral rehydration solutions, even if it doesn't quite meet that 90 to 100 MEQ range, because it's really important to get these fluids in. Oral rehydration solutions taste better when they're chilled, so recommending patients keep these fluids in the refrigerator versus at room temperature. Again, sipping slowly on the oral rehydration solution throughout the day instead of chugging or drinking a large volume at once. And keeping in mind that oral rehydration solutions are used to maintain adequate hydration, not to replete a large volume loss, such as high ileostomy or jejunostomy outputs. So for some patients with chronic high output, no matter how much oral rehydration solution they drink by mouth, they may never be able to keep up with their fluid needs and thus require additional IV hydration. Just shown here on the screen is an example recipe for a homemade oral rehydration solution. So an example is 3/4 of a cup of juice, 3 1/4 cup of water, and then 1/2 to 3/4 of a teaspoon of salt. So another example is using a low sugar sports drink and mixing this with additional salt to create that optimal ratio of the glucose and the sodium. So you could take a 32-ounce bottle of a lower sugar sports drink and then add that 1/2 to 3/4 of a teaspoon of salt. So enteral nutrition. So when might we use EN in a patient with short bowel syndrome? So oftentimes enteral nutrition is used short term after an extensive bowel resection or in an attempt to wean a patient off parenteral nutrition. It's recommended to use a continuous infusion into the stomach versus a bolus mechanism, and this is because this presents a lower dose of the nutrients per centimeter of small bowel remaining in hopes to maximize absorption potential. When selecting a formula for EN, isotonic or as close to an isotonic formula is recommended. Some patients might require a semi-elemental formula just dependent on tolerance to an isotonic traditional formula, but it's not that every single patient with SBS needs to use a semi-elemental formula. Also considering the fact that a majority of the elemental formulas are hypertonic, these should be avoided in patients with SBS. And soluble fiber containing formulas can be beneficial for the patient with a colon in continuity. Moving on to parenteral nutrition. So most patients with SBS will require PN at some point, or they may require it lifelong. The goal is always for intestinal adaptation and eventual weaning off of TPN. However, this can take several years to achieve. Those that have their colon in continuity or most or all of the segments of their small bowel have the most success when weaning off TPN. The greatest risk of chronic intestinal failure and lifelong PN dependence is for patients with that angiogenestomy. So when we're considering those patients that have the greatest risk of chronic intestinal failure and lifelong PN dependence, we need to look at how much small bowel is remaining and what type of small bowel they have remaining. So for those that have an angiogenestomy or ileostomy, if they have less than 115 centimeters of functional small bowel, this most likely means this patient will be PN dependent for life. As you can see, the amount of functional small bowel needed to wean off TPN is reduced when a patient has their colon intact. So for those that have no ileocecal valve, less than 60 centimeters of functional small bowel might mean long-term TPN. And for those patients with an ileocecal valve and a colon intact, PN dependence for life is really only seen in those with less than 35 centimeters of functional small bowel remaining. So in a patient on parenteral nutrition with SBS, the formula of the PN is constantly being adjusted based on intake, tolerance, and degree of absorption of enteral nutrition. So whether this is a patient on an oral diet or tube feeds, or perhaps a combination of both, we're ever changing that TPN formula based on how much nutrition they're getting enterally. It's really important to note that fluid needs can vary drastically in this patient population, and this is just due to the degree of GI losses. Thinking, ostomy outputs and how drastically those outputs can change on a day-to-day or month-to-month basis. It's important to adjust your fluid in the TPN to accommodate the GI losses. TPN should be cycled over 12 to 16 hours, ideally, in order to minimize risk of PN-associated liver disease. And micronutrient levels should be monitored periodically, such as every 6 months in the long-term PN patient. It's important to note that some patients might be able to wean off PN, but still require parenteral hydration only. Examples of fluids that are best suited for this patient population are normal saline or lactated ringers. Some patients will require a bag of fluids such as a liter or several liters of fluids, which are infused over a couple hours each day to maintain their hydration needs. So looking at the pharmaceutical and surgical management of SBS, there are several medications available to help treat complications of SBS. So these include antidiarrheals, antisecretories such as PPIs or H2 receptor antagonists. Bile acid sequestrants are also used for patients with fat malabsorption. Octreotide is a common medication used in this population. GLP-1 and GLP-2 analogs can be used specifically to help enhance the absorption of remaining small bowel in hopes to wean a patient off of TPN or IV hydration. And then looking at surgery, so oftentimes reversal surgeries, such as a takedown of a jejunostomy, can help wean a patient off of chronic TPN. And then ultimately, if other pharmaceutical measures have not helped and a patient has complications of SBS, intestinal transplantation is considered. So moving on to a case study. So this case is a patient that is a 55-year-old male who has history of diabetes, peripheral artery disease, who was admitted to the hospital with postprandial pain. A CT abdomen pelvis was obtained, and the patient had evidence of intestinal ischemia. So the patient was taken emergently to the operating room for a small bowel resection and creation of a jejunostomy. So after the surgery, the patient had 120 centimeters of small bowel remaining. So as the dietitian, a consult was received to initiate TPN on post-op day 2, and the rationale behind this was anticipated prolonged NPO status, and the surgeons had the intent to send the patient home on TPN until a patient could undergo a jejunostomy takedown in about 6 months. So the patient is 5'7" or 170 centimeters, 160 pounds or 72 kilograms, BMI of 25, and when completing your NFPE, there was no evidence of muscle or fat wasting. So the patient is now on TPN, their post-op day number 5, and listed here are the patient's lab values for the day. Important to note is the patient's I's and O's. So the jejunostomy output was 2.7 liters in the last 24 hours. The patient is also on a low fiber diet in addition to the TPN. And medications include loperamide, 2 milligrams, which is scheduled 4 times per day. The TPN formula is listed below, and important to note is the total volume is 2,000 milliliters over 24 hours. The macronutrients include 275 grams of dextrose, 110 grams of amino acids, and then 45 grams of lipids, and we're using a soybean oil-based lipid emulsion. So the first question is, what lab abnormalities stick out? So when I'm looking at these labs, what's concerning to me is the sodium level is low at 132. The potassium level is slightly low at 3.4. Chloride is high at 118. The CO2 is low at 13. The BUN and creatinine appear to be slightly elevated as well. However, it's important to consider this patient's baseline creatinine and trends over time. Also, the magnesium is low at 1.4, and the glucose is elevated at 212. So what might be causing some of these electrolyte derangements? Looking at the elevated BUN and creatinine, the low sodium, the high chloride, these all point me to think that this patient is dehydrated. So when we're looking at the volume of the TPN, this patient's getting 2,000 milliliters. When we're looking at the outputs of the jejunostomy, this patient's putting out well over that 2,000 milliliters and closer to 3 liters of fluid. So it's important to consider what oral fluids the patient's taking in, if they are getting additional IV fluids on top of the TPN. But based upon these labs, it appears to me that the patient is not getting enough fluid to keep up with his GI losses. Other things to keep in mind when looking at the lab results, the magnesium is low. So it's common to see a low magnesium level in patients with SBS, specifically those with high output ostomies. These patients are losing a lot of magnesium with their high ostomy output. So it's important to not only replete these electrolytes intravenously with IV riders and make adjustments to the TPN formula to make sure we're monitoring and getting those magnesium levels to a desirable range. Also, the potassium level is slightly low, which could be attributed to GI losses as well. So again, here, important to replete intravenously versus oral repletion of these electrolytes, and closely monitor labs and adjust your TPN prescription. So for these patients, especially when we're starting off TPN, I like to get labs at least twice a day just to make sure we're maintaining those electrolytes within normal range and not getting too behind with repletion. Another important lab to look at is the glucose level. So we know that this patient has history of diabetes, so the elevated glucose could be due to that. could also be to a stress response after surgery, but it could also be related to the TPN. So, our bodies are not used to getting IV dextrose around the clock. So it's really important to closely monitor blood glucose levels when you're starting TPN. Patients might require an adjustment of the dextrose level in the TPN, or they might require insulin to be added to the TPN or outside of the TPN. So important is management of the patient's ostomy output. So like we discussed, the ostomy output was 2.7 liters in the last 24 hours, which is a significantly high amount of GI losses. Thinking about medication management. So this patient is on the 2 milligrams loperamide 4 times a day. It's really important that this medication is given pre-meals if the patient's on an oral diet, so the drug has optimal effectiveness. So this patient is only on 1 antidiarrheal medication right now. So there is lots of room to go up on the medications, also considering adding an anti-secretory. Again, all of these decisions should be discussed with the medical team taking care of the patient, but as a dietitian, it's important to know what medications are common in SBS patients and how we can optimize their medications in order to wean off TPN or reduce the amount of fluids a patient needs on TPN. So when I'm considering modifying the TPN regimen for this specific patient, I want to look at the fluids. So we're only giving a patient 2,000 milliliters of fluids right now in the TPN, which is not even replacing what the patient is losing in their stool. So dependent on weight and other factors, say this patient needs at least 2 liters, just baseline for their fluid needs, we would want to add additional fluid on top of that to the TPN to replace these losses. So I definitely would say we have room to go up on the fluids in the TPN. I also would consider the cycle length of the TPN. So for this guy, we are planning to send him home on TPN. So we definitely don't want to send him home on a 24-hour regimen, which is not ideal for the home setting. So I would want to cycle his TPN to 12 to 16 hours for home. However, it's important to consider in SBS patients the duration they're on TPN. For a traditional patient on home TPN, say for a bowel obstruction or something like that, they might be okay on a 12-hour infusion. However, for these patients with high GI losses, we might need to send them home on a longer cycle of TPN just because they're at higher risk of becoming dehydrated and can use those additional hours of fluids on the TPN. It's also not uncommon for a patient to be on a cyclic TPN at home and then receive additional IV fluids on top of that based upon their outputs. For dietary modifications for this guy, so he is currently on a low fiber diet. He definitely will need extensive education on what foods are better choices for him in order to minimize his outputs. Focusing on those complex carbohydrates, focusing on the high protein intake, the small frequent meals for him, and most importantly, his fluids. So providing examples of oral rehydration solutions, how to make those, how to sip those throughout the day. These are all points you'd want to bring up with this patient. Another question that might be asked is, should this patient be on an oral diet at home? So in patients with chronic intestinal failure or those that are going to be on home TPN for a long time, I think it's important to consider enteric stimulation to reduce the risk of PN-associated liver disease. So while I think it's fine to send this patient home on an oral diet, I think this diet should be more so for pleasure and less for the nutrition aspect of it. Having a patient on pleasure feeds can help with their quality of life, but you again want to make sure your patient is selecting the right foods to be eating at home that aren't going to exacerbate outputs. And with a patient going home on an oral diet, it's also important for strict intake and output monitoring. So we want our patient to record how much fluid they might be drinking by mouth, and then how much ostomy output they're having at home, to make sure we're not drinking fluids that might be exacerbating output, and to make sure we're giving them enough IV fluids to replace their losses. So with that, I think this sums up our segment on short bowel syndrome. I thank you guys for watching so much. And if you have any questions, feel free to leave them in the comment section below. And we look forward to seeing you next time.